Hello, let's talk about hemorrhagic diatheses. What's that? Well, bleeding problems means somebody just can't stop bleeding. So what are some examples? Well, maybe you're like me and you're shaving and you kind of cut yourself. I mean, why do you think I have a beard? And it's like 15, 20 minutes later and you still haven't stopped bleeding. That would be an example of a prolonged bleeding time, which is just time from the cut to time it takes to stop bleeding. Or maybe you've had a dental procedure, a tooth pulled, or maybe you were just flossing or brushing too hard. And again, it's 20, 30 minutes later and your mouth is still bleeding. So that'd be another example of a bleeding prolongation. Or maybe it's something a little bit more serious than just a cut or a scrape. Maybe you had a surgery, like an appendectomy, and maybe they stitched it back up, but you rolled over in bed the wrong way, and that internal stitching just reopened because you had a clotting factor insufficiency, and things got very bad. You could bleed to death from that. Maybe it's a patient with a persistent nosebleed, epistaxis, indicative of a platelet problem, inability to stop the initial bleed. Maybe it's a patient with menorrhagia coming in complaining of heavy menstrual bleeds. A lot of different ways to spin it, even the hemarthrosis, bleeding into a joint cavity. That's very common with the clotting factor anomalies. So many different signs and symptoms. You're going to have a good suspicion for when a patient is bleeding. Let's talk about normal hemostasis. Well, first, let's talk about where we're going with this SDL and how you'll apply the things that you'll learn within. We've got some big tests that we use to evaluate causes of prolonged bleeding. And on this chart, two of them, platelet count and bleeding time, are evaluating platelet function. And the other two, prothrombin time, partial thromboplastin time, those are evaluating clotting factor function. So we've really got four big tests for bleeding problems, and two of them have to do with platelets, two of them have to do with factors. That makes a lot of sense because hemostasis is always a two-man job. Any vessel in your body, anytime it gets injured, there are two things that have to happen sequentially in order to successfully stop that bleed over the long term. First, there has to be a platelet plug. So you obviously need platelets to be able to make that platelet plug. And those platelets have to be able to stick together and to stick to the wall of the endothelium. And if that can't happen, you're not going to get a proper platelet plug. So that's the first half of hemostasis. After you get a platelet plug, just because they have platelets there doesn't mean you're done. Those platelets are held together by very weak interactions. And that's where our clotting cascade comes in. By laying down activated factor 1, fibrin, we kind of put a blanket of glue over a platelet plug to ensure that it stays right there in one place until granulation tissue is formed and the wound is done healing. So the second part of hemostasis, invariably, every single time, always following platelet plug formation, is going to be sealing up of the platelet plug by fibrin cross-linking, which is at the very end of the clotting factor cascade. So my first big point is that this right here, your intrinsic and extrinsic pathways, is this important? Oh yeah, you better believe it is. But what I really want you to know right off the bat is that this stuff only matters after a platelet plug is formed. This stuff only comes into play after the platelets have stuck to the wall of a vessel and then aggregated with one another and done their thing. So let's please start off by discussing the first part, this two-step process, the platelet plug. So you get some endothelial injury. There's your bleed. That's what a bleed is. Injury to the endothelial lining of your vasculature. What's the very next thing that happens? Well, endothelium kind of scoots aside to reveal some collagen on the basement membrane that lines every blood vessel in your body. And endothelial cells release some vasomodulatory chemicals that are going to vasoconstrict a territory or section of injured vasculature. Vasoconstriction is going to be right there at the start of things. Why? Because when you're injured, you've got a hole in the wall of a blood vessel, you want to clot it over and you want to seal that hole. So platelets are what do that. And if there's a lot of blood flow in a region, you know, think about a vasodilated vessel like a 5-lane interstate. And all 5 lanes, cars are going 70, 75, 80. Versus think about the interstate in a section with heavy construction or a wreck. And think about that bottleneck. When traffic goes from 4 lanes to 2 lanes or even 1 lane, it gets really slow, doesn't it? You're sitting there for a minute, you know, like you're pulling out your phone, you're doing this and that. You're like, can we please move? That's a vasoconstricted capillary. So with the slower blood flow, when you make a platelet plug, it's not going to get blown off by the extreme amount of blood traffic going through the vessel. Instead, when you're vasoconstricted, it's slow enough to where the plug stays on the wall. That's why we vasoconstrict when there's endothelial injury. So you vasoconstrict and you've got some collagen exposed. Now what? Well, endothelium also makes this component called von Willebrand factor, which is just glue. It's platelet glue, and it's supposed to help platelets stick to the wall of an injured blood vessel. And endothelial cells make von Willebrand factor, and so do platelets. Megakaryocytes actually make a little bit of this platelet glue and send it out with platelets, because remember, platelets are originated from megakaryocytes that live in the bone marrow, and they just pinch off these platelets and put them into circulation. So when they do, they give them a little von Willebrand factor so that when that platelet is hiking through the bloodstream and that platelet sees some damaged endothelium, it can say, all right, I can take care of that. I can stick to this wall. So endothelial cells and platelets make von Willebrand factor that adheres platelets to an injured cell wall. Here's kind of what that looks like on this slide. See down here at the bottom, circle 1, circle 2 show you von Willebrand factor connecting to endothelial collagen. And then how does the platelet stick to that von Willebrand factor? That would be glycoprotein 1b. So anytime you see a glycoprotein, GP1b or GP2b or GP this or that, what that means is that the platelet is sticking to something else. So in this case, it's, again, the vessel wall. First, your platelet has to stick to a vessel wall before it can think about sticking to other platelets. That's why it's called GP1. It's the first glycoprotein that's activated. So platelets stick to von Willebrand factor, right? And now you've got a couple of platelets stuck to an injured blood vessel wall. What happens next? Well, binding glycoprotein 1b sets off a chain reaction within platelets, and they'll degranulate, similar to mast cells in a type 1 hypersensitivity, and they will release factors that they make on their own that will encourage platelet aggregation and further vasoconstriction. So we said that being in a vasodilated blood vessel to a platelet is like playing Frogger on a 5-lane highway versus being in a vasoconstricted blood vessel, that's really easy. It's so easy to just stick on the wall. There's no motion around me. So thromboxane A2 is a vasoconstrictor that platelets make. And in fact, they're the only cells in the body that can make thromboxane A2. And TXA2 is downstream from prostaglandin H2, and PGH2 is downstream from arachidonic acid. And so you need to send arachidonic acid through cyclooxygenase in order to make the prostaglandin. You need to make thromboxane. So if somebody is on a non-steroidal anti-inflammatory that is going to block COX, then you're going to have a platelet aggregation problem. And that explains why bleeding is a frequent side effect of non-steroidals such as Advil. So platelets not only make thromboxane to vasoconstrict, they also make ADP, that's adenosine diphosphate, not mono, not tri, diphosphate, and it plays a really important role in platelet aggregation. Quickly, how did we get to this point? Well, we said that you got an injury and that exposed some collagen, and endothelial cells made some von Willebrand factor that helps platelets stick to the vessel wall with glycoprotein 1b. And when that is bound, that's going to cause platelets to make some ADP, and ADP is going to loop back around and act in an autocrine manner on your platelets to get them to put glycoprotein 2b3a onto their surface. So ADP tells you to put glycoprotein 2b on the surface of your platelets. And now this is really convenient. It's not that bad, is it, huh? You see glycoprotein 1 is the very first glycoprotein that's activated, and you need to bind the platelet to the wall of the endothelium before you can think about binding platelets to other platelets. But when you're ready for that, glycoprotein 2 is going to be the one that's activated. It's the second one that's activated. And so it's like, okay, this is no problem at all. Platelets are easy. Cool, right? Pretty much. Here's an electron micrograph, scanning electron microscopy of a clump of platelets. I swear this is what they look like, yo. Just little tentacled things out here, just trying to stick onto a flat surface. And again, this coagulation of platelets stimulated by adenosine diphosphate, which is going to upregulate surface glycoprotein 2b3a, which a lot of drugs inhibit: abciximab, tyrifibin, eptifibatide. So those discourage platelet aggregation. So we would use those if we didn't want someone to get a clot. That's the receptor involved. Here's another look at a platelet plug. Here's one 5 minutes post-injury, right? So this happens pretty quickly. At any point in time, at anywhere in your body, the elements that you need to make this platelet plug are in your bloodstream. All over the place, all over your body. Pretty cool too, even shows you with this yellow arrow down here, the direction that the fluid's moving in. You can tell it's kind of buffeting those platelets and getting them to bend in the direction of blood flow. So that's a platelet plug. And to bring it back a little bit to the big picture, you're going to want to understand that bleeding time is a measure exclusively of platelet function. So everything that we've discussed up to this point, the formation of the primary platelet plug, that's bleeding time. And how the test works, it's real simple. You just stick a hole in somebody and you tell them that you're going to do it. You know, you don't just run up to somebody and put a hole in their arm and then click stopwatch. You tell them you're going to do it, punch a hole in their arm, let's go. Okay, bleeding time is started. Now you're waiting and you've got a little disc or a Kleenex or whatever, and you're just dabbing off blood every 30 seconds or so from this puncture wound. And whenever you can't get any more blood from it, that's how you know, okay, this thing's got a platelet plug on top of it. It has stopped bleeding. So that's when you stop the stopwatch. That's the end of bleeding time. So as you can see, we have not talked at all about coagulation factors up to this point. Should tell you that bleeding time as a test has nothing to do with factors. It's exclusively a measure of platelet function. That's really important. And then platelet count, obviously, that one also has nothing to do with factors. That's just a pure quantitative test. So platelet disorders, then, we can diagnose really just with those two things, knowing that PT and PTT are going to be normal. So getting a little bit further into the woods, then, what are PT and PTT anyways? Well, they're measures of clotting factor efficiency. And your clotting pathways, both intrinsic and extrinsic, are going to be underway simultaneous to the formation of the platelet plug, but they're not going to interact with a site of injury until the primary hemostatic plug is done. So first you form your platelet plug, then your clotting factors come in, and the way that they interact with it is that fibrin, which is activated factor 1, is going to just sit down on top of platelets and hold them together. That's it. It's that simple. It really is. And so all these Roman numerals up here are just the steps that are required to get to fibrin down here at the bottom, which is again that activated factor 1. And once fibrin is sitting holding these clots together, then you got some factor 13 that's going to go and stitch that fibrin up and adhere it to platelets, and that's a stable clot. Okay, so that's a clot that can really stand the test of time there. And intrinsic and extrinsic pathway, those are both going to lead to factor 10. So activated factor 10 is the common endpoint for both of these pathways. It's analogous to complement, right? You've got a traditional complement activation system in which you could go through 1 and then through 2 and then through 2, 4 into 3 convertase, right? Or you've got a couple other branches of how you could activate complement, and they're totally blanking my mind right now. But I do remember that there's many ways to get to the common C3 in complement. Now, intrinsic, extrinsic pathway. First off, inherited coagulopathies typically mean that somebody is missing one of their clotting factors. And the prime example of that would be hemophilia, in which you're just missing factor 8. So right here, where factor 8 is, if you're a hemophiliac, you have every other factor in this table except for 8. That's it. And in von Willebrand's disease, you also have a factor 8 deficiency. There are other variants of hemophilia. You might have a 9 deficiency. Okay, you might have an 11 deficiency. So how we measure these things in the intrinsic pathway is going to be through PTT, partial thromboplastin time. Now, extrinsic pathway, it's really factor 7 activated in tissue factor, and that's it, straight up. And that's going to be our prothrombin time. So the connection is that we use PTT and PT to monitor anticoagulants that we put patients on as therapy. And this is where it gets a little confusing to me because I don't know the specifics. So get this. Patients on warfarin. What does warfarin do? It's a V-core inhibitor, vitamin K oxidoreductase. And so you're not going to be synthesizing certain factors de novo, including 2, 7, 9, and 10. Well, as you can see, 7 is in the extrinsic pathway. Now, 9 is over here in the intrinsic pathway. 10's in the middle of both of them, and 2 is way down here, prothrombin and thrombin. So if you're on warfarin, you're prothrombin time, your PT, the time that it takes for your extrinsic pathway to go from start to finish is going to be prolonged or elevated. However, because you've also got some factor IX inhibition, your partial thromboplastin time, your PTT, the time it takes your intrinsic pathway to go from start to finish, that'll also be prolonged. And guess what? Same thing for heparin. Same exact thing for heparin. Because in heparin, what's heparin do? It encourages antithrombin 3, promotes antithrombin 3, which puts a hold on factor 10 and factor 2. So factor 10 is a common factor, and prothrombin, that's a common factor. So if you're on heparin, what's that going to do to your prothrombin time? It's going to be prolonged. It's going to be elevated. And then same thing for your partial thromboplastin time. That will also be elevated. So in heparin and in warfarin use, I want you to understand both PT and PTT will be elevated. They both will be. However, the test that we use to monitor the efficacy of the heparin or the warfarin that we're given, that's going to be different based on things that I don't understand. So that's where I'll say I don't get it anymore. You know, why do we use PT for warfarin but not for heparin? PT is just a better measure of warfarin function. That's all I can say. Likewise, why do we use PTT and not PT for heparin? Well, PTT is just a little bit more specific for heparin function. It's a better measure of its function relative to any other drugs patient could be on. But again, big takeaway, both PT and PTT are elevated in both warfarin and heparin use. And last but not least, I'm going to say this one more time. All of that clotting factor stuff can only happen after primary hemostasis, formation of a platelet plug. So first the platelet plug gets made, then you throw some fibrin on it. That's it. Now let's get into the pathologies of this SDL. And again, the SDL is on bleeding problems. So the question is, what are some things that can make you bleed? And one category of things that can make you bleed is problems with the wall of a blood vessel. So these are very straightforward, easy to understand. If you keep poking holes in a tube, it's going to keep leaking. And the hallmark of vessel wall abnormalities is normal labs. Totally normal platelet, quantitatively, qualitatively, totally normal factor tests, PT and PTT. Everything's normal. Patient just keeps bleeding. So you're thinking vessel wall problem. What could cause vessel wall stress? Well, in my mind, first thing that pops up, probably most common, would be a type 3 hypersensitivity. Remember, that's immune complex deposition that can cause peripheral leukocytoclastic vasculitis. And so white blood cells, neutrophils particularly, are involved there. Why? Well, because when you get an immune complex stuck in the wall of a blood vessel, remember that's just an antibody bound to an antigen. So if it gets latched onto the outside of an endothelial cell, then it's kind of got a chemotactic function. And so your white blood cells are going to swarm and jump on that immune complex and then degranulate and cause some tissue injury, thus blasting a hole in the wall of your vasculature. That's type 3 hypersensitivity vessel wall damage. Also, infections, lots of different virulence factors out there that are harmful to endothelial cells. Now, when you get to the point of septicemia, that can present with other problems such as DIC, but before it does that, it's going to really tear up your endothelium. So again, you put a hole in a tube, it's going to leak. Scurvy and Ehlers-Danlos, these are structural problems. Scurvy being a vitamin C deficiency, and you need vitamin C to cross-link collagen, which is just repeating, I think it's proline, lysine, glycine motif, just a trinucleotide repeat. And you, again, cross-link that with vitamin C. And Ehlers-Danlos is a heritable deficiency in collagen 3 or 5, which is in the basement membranes throughout the body. So if it's not knit tightly together, it's going to leak some water there. Henoch-Schönlein purpura, that's another type 3 hypersensitivity immune complex origin. Then there's Osler-Weber-Rindu syndrome, also known as hereditary hemorrhagic telangiectasias. So you inherit these small little blood vessel abnormalities all throughout your body, and they have a tendency to bleed, and they can be both on your skin and within your GI tract. So these patients very often have an iron deficiency anemia, actually, that's secondary to occult blood loss from their stomach or their duodenum or wherever these little bleeding spots are. Got one slide that looks at a patient with Osler-Weber-Rindu. They tend to have these petechia on the mucous membranes of the mouth. And then down here in the lower right is an example of a GI scope, and there's just these point hemorrhages that you can see on the gut mucosa. And again, that can be a source of blood loss. So in this patient, PTT, totally normal. They don't have a problem with their clotting factors. Bleeding time, totally normal. Any thrombocytopenia, maybe a little bit if they've got an active bleed, but at rest, no. So normal labs, but they're still bleeding. And then amyloidosis. Just remember that amyloid light chain. You see that. What do you think? Multiple myeloma. So now we get to platelet problems. And telling platelet problems apart from factor problems is the heart of this SDL. Symptoms that make you say, oh, the patient has a platelet problem. Petechiae. You really don't see petechiae with clotting factor problems because the patient's got no problem making the initial plug of a bleed. Problem is, in a clotting factor deficiency, there it is, patient has no problem making that platelet plug. So they're way less likely to get this petechiae. Same thing with a nosebleed. If you have a nosebleed that just won't go away, what that's telling me as a clinician is that the bleed can't self-resolve. And so I know that the very first step in that process is the formation of a platelet plug. So if you can just get a platelet plug there, even if you can't cross-link it if you're factor deficient, you'll at least be able to stop the initial bleed. So there will be no problem with your bleeding time if you have a factor problem versus platelet disorders, which are characterized by their elevated bleeding time and their normal PT and PTT. So petechia, recurrent nosebleeds, elevated bleeding time, that's a platelet problem. Now, we can divide those up into thrombocytopenias, problems of platelet number, you just don't have enough, or thrombocytopathies, your platelets are weird. Even if you had all the platelets in the world, they still wouldn't work right. That's a thrombocytopathy. Different thrombocytopenias, we're going to call it low platelets when you're below 100,000 of them per cubic millimeter. Again, you've got a normal PT, normal PTT, indicating your factors are totally fine, has nothing to do with your factors. What could give you a thrombocytopenia? Well, it could be a bone marrow problem, such as aplastic anemia or myelofibrosis, right? Because where do platelets come from? Megakaryocytes, those are just platelet factories. And where do those dudes live? In your bone marrow. So if you don't have a lot of bone marrow, then you don't have a lot of platelets. Or there could be something happening in your bloodstream to kill platelets and just take them out one by one as they're swimming through your blood. And an example of that is an immune thrombocytopenia, which I'll have you know is the exact same thing as an autoimmune hemolytic anemia. There's an antibody that recognizes something on the surface of a platelet. And when that antibody sticks to a platelet, typically it's IgG, that platelet makes it around to the spleen. Splenic macrophages see that IgG and they pull that platelet and they pop it. So that's an immune thrombocytopenia. Pretty easy stuff. And that does like to be post-viral because of molecular mimicry, or usually following exposure to a new therapy, new drug. That's typically the trigger that gets the ball rolling on that molecular mimicry to give you an immune thrombocytopenia, which, by the way, is a type 2 hypersensitivity, antibody-dependent cell surface cytotoxicity. And besides autoimmunities, a couple of ways to acquire a thrombocytopenia, and these are associated with some pretty bad conditions. Number one being sepsis. You got a bacterial infection and it's uncontrolled and it's systemic. Well, then DIC is just a couple of days right around the corner. And then thrombotic microangiopathies. Those include TTP and HUS. Talk about those in just a few seconds. First, there's immune thrombocytopenic purpura. So thinking about this, immune, it's because your immune system is doing this to you. You've got low platelets and you've got a rash, you've got a purpura. So the patient has low platelets and a rash, and you don't know why, because this is also called idiopathic thrombocytopenic purpura, which is what we call something when we don't know why it's happening. So this can be primary or secondary, and primary is really the most common. Secondary would mean you know why it's happening, and it's because of, again, typically molecular mimicry, post-infectious, or following the start of a new drug. Drugs such as quinine, that's an anti-malarial, and TMP-SMX, sulfa drug, those can get the ball rolling on this antiplatelet reaction. And whenever you have autoimmune-related destruction of platelets, you'll see some things in the circulation that are just analogous to if you saw autoimmune hemolysis. You'll see really big platelets, you know, like how you'll see reticulocytes. If there's an anemia, you've got a lot of EPO, so that tells your bone marrow to pump out some reticulocytes, which are a little bit bigger than normal red cells. So that's your large platelets in the blood. And then also, if you did a bone marrow, you'd see an increased number of megakaryocytes. Just like how if you had an anemia, you'd see an increased degree of erythropoiesis if nothing's wrong with the bone marrow. So that's thrombopoiesis. Same exact thing that happens with red blood cells, just with platelets. Clinical presentation, good paragraph to read again. How do I know the patient's got a platelet problem? Well, small scratches just don't close easily. Prolonged bleeding time is the hallmark test. PT and PTT are normal. Often there's a history of easy bruising, nosebleeds, and bleeding from the gums. Patients might have occult fecal blood, melena, or hematuria, or excessive menstrual flow. And obviously, the number one way to say, hey, this patient's got a platelet problem is you get their blood count back and they've got low platelets. So great time to be a doctor. Modern medicine, love it. Drug-induced thrombocytopenia. Again, this is bringing up platelet inhibitory drugs that bind GpIIb3A, which you remember is the glycoprotein that anchors platelets to platelets, because we said anytime you see glycoprotein, this or that, in relation to platelets, it means one platelet is sticking to something else. It's always an adhesion molecule. So GP1b, that's the first glycoprotein that you use, and so that's going to stick a platelet to an injured vessel wall. And then glycoprotein 2b, that's the second glycoprotein you use. It's going to stick platelets to other platelets. And so there's a drug that inhibits that. It's called ipsiximab. It's a monoclonal antibody. A couple others that do, eptifibatide and tyrofibin. So if you inhibited glycoprotein 2b3a, then your platelets are just going to say, all right, dude doesn't need any of us. And that's going to give you thrombocytopenia. And we also got heparin-induced thrombocytopenia. This is a big one to know. What does heparin do? Heparin enhances the activity of antithrombin 3. So it's a natural anticoagulant. And really, heparin is not what's doing the anticoagulation. It's this antithrombin 3 that's doing the anticoagulation. So that's the anticoagulant. Heparin just gives it a little boost. And antithrombin 3 is going to totally neutralize certain factors, specifically 10 and 2. And again, those are pretty important because 10 is where the common factor pathway starts. The intrinsic and the extrinsic both lead to factor 10. 2, that's even further downstream. So both the intrinsic and the extrinsic lead to factor 2, which is why if a patient is on heparin, they're going to have a prolonged PT and a prolonged PTT. Now, if you give someone heparin, you might see an autoimmunity against platelets that activates those platelets. And that's heparin-induced thrombocytopenia. You give someone the drug, it makes a complex with platelet factor 4, heparin plus platelet factor 4, and this shape attracts an antibody, and when the antibody binds to this heparin platelet complex, the platelet degranulates and goes and puts von Willebrand factor on a wall and sticks to that wall and grabs other platelets. It's platelet activation. It's like, duh, that's what happens. So what does that lead to? That leads to systemic clotting. And whenever you're clotting all over the body, well, if you do a blood draw on somebody who's got a lot of active clots, they're not going to have a high platelet count because all those platelets are tied up in active clots. So that's why a low platelet count actually often reflects a high degree of platelet activity. They're being used. You're not going to get them in a blood draw if they're being used somewhere. So that's heparin-induced thrombocytopenia. And how do we prevent it? Low molecular weight heparin. Autoimmunity against platelet factor 4 plus heparin. Now we've got thrombotic microangiopathies, TTP and HUS. So here's how I'll explain this. HUS is 3 things and TTP is HUS plus 2 other things. Got it? A couple other differences. HUS typically pops up in kids. And again, typically it's following a gastrointestinal illness or perhaps concurrent with it. So kids' stomach really, really hurts. That's because HUS is related to a particular bacterial toxin, Shiga toxin in Shigella species and Shiga-like toxin in EHEC, enterohemorrhagic E. coli species. So those are the 2 most common causes of hemolytic uremic syndrome. Bacterial infection, they're gram-negative enterics, kid gets an upset stomach, and then a few days later, his kidneys are failing, or hers, and kid's got an anemia, and finally, tying it back to this SDL, a thrombocytopenia, because this toxin, this Shiga-like toxin, makes you bleed. It damages endothelium. When endothelium gets damaged, what happens next? Clotting. So, clotting is actually the first thing that happens in this disease. And following the clotting, you get a microangiopathic hemolytic anemia. So your red blood cells start running into these clots in your microvasculature. And when a red blood cell hits a clot at 80 miles an hour, it's not pretty at all. You know, in fact, these red blood cells come out way, way worse due to it. They look like these schistocytes. These are called helmet cells. And I mean, these things are really torn up. So you see a bunch of these in the blood, and that is a sign to you, especially when you see them along with the thrombocytopenia. That's a sign that there is some hemolysis occurring secondary to clots in small vasculature. Now, following that anemia, there's going to be an acute kidney injury. Actually, I think the kidney injury is due to the toxin itself, not because of the clots. But I'm not sure about that. So it's a triad. You've got a kid who's got an upset stomach with a gram-negative bacterial infection, which could be due to Shiga toxin, which binds the 60S ribosomal subunit, or it could be due to EHEC, which you got to know that O157H7 serotype, right? And how do you get that? Eat some bad hamburger meat, typically in the stem of the question. Kid ate meat. And again, that's got a Shiga-like toxin, functions very similarly, binds that 6DS ribosomal subunit. Diagnose it with a thrombocytopenia, anemia, AKI. So TTP is going to be that stuff in adults, and they'll also have a fever, and they'll also have some neurologic involvement. Could be generalized confusion, could be maybe they're not localized to person or place or time. And as opposed to being affiliated with a specific pathogen, thrombotic thrombocytopenic purpura is related to an enzymatic deficiency. And listen up, this is usually acquired. Usually just one day out of nowhere, patient no longer has any of this enzyme. And that's very often autoimmune in origin. There will be autoantibodies directed against the particular protein produced by this gene. And that will totally wipe out its activity. So that's what's going on. It's an enzyme deficiency that leads to thrombocytopenia and easy bleeding. So it's thrombotic thrombocytopenic purpura, TTP. What's that mean? Thrombotic, the patient is clotting a lot. Thrombocytopenic, you don't have any platelets. Purpura, there's this little rash of spots, they're purple and red, like 1 centimeter each. It's a purpura. So this is actually a disease does two opposite things at once. You're clotting everywhere, but that's using up your clotting factor so that eventually you can't form a clot. So it's the adult version of hemolytic uremic syndrome. How you're going to diagnose these things is with a prolonged bleeding time and a normal prothrombin time, partial thromboplastin time. Now we've got thrombocytopathies, in which you see a normal platelet count, but the platelets don't do anything. So you'll have 300, 350,000 platelets per cubic millimeter, but they're not going to be working for anything. And the really cool news about these is that you got two of them to worry about, these thrombocytopathies, and they're both named after somebody. So if you just remember, these are the platelet disorders that are named after somebody else, then you got both of them. And then it gets even easier, actually, because they both have to do with platelet glycoproteins. Bernard-Soulier syndrome is a deficiency of GpIIb. So you know that that means platelets can't bind to injured endothelium. All right, check. And so how do platelets bind to that endothelium? Von Willebrand factor. Check. Now, if a platelet can't do that, what's your blood platelet count going to be? Normal or even elevated. But what's your bleeding time going to be? Elevated. So it's going to be basically a typical thrombocytopenia, but with a normal platelet count. And Glanzmann thrombasthenia, same thing there. Patient does not have glycoprotein 2B3A. So very, very similar there. It's a glycoprotein deficiency. And you're going to see a normal platelet count again, but the platelets just won't work because they can't adhere to one another. So you never get that primary hemostatic plug. And finally, talking about qualitative defects in platelet function. Actually, the most common cause of a functional platelet disorder is taking aspirin, because that's a cyclooxygenase inhibitor. When you do that, you stop making thromboxane A2, And understand that's a very potent vasoconstrictor, and it's very tough for that platelet plug to form when there's a large volume of blood flowing through whatever capillary. So aspirin, most common cause of a prolonged bleeding time. It's an irreversible inhibitor of cyclooxygenase. I actually got the question, like, how does this drug interact with the enzyme? A lot of different answer choices, and one was like increased Km, like your Michaelis constant, and then decreased Vmax. And so the point was they were asking you if aspirin was reversible or irreversible, because a reversible inhibitor can be overcome with substrate, but an irreversible one cannot. And so it's going to decrease the maximal velocity, whatever reaction. So you can't overcome aspirin with more platelets, is what I'm saying. You really can't. So that's a bunch of platelet stuff right there. Let's talk about clotting factors now. As opposed to bleeding due to platelet problems, bleeding due to clotting factor problems tends to be more severe and involving a larger surface area. If you can't make a platelet plug, then you get a small little scratch and it'll just keep bleeding all over the place. That's a platelet problem. If you have a clotting factor deficiency, you get a small little scratch and it'll heal right up because there's nothing wrong with your platelets. However, if you move that scab, it's going to start bleeding right again because the platelet plug never gets cross-linked if you have a clotting factor problem. Some characteristic presentations would be patient who has a wisdom tooth out and the bleeding just will not stop. And that's because taking a tooth out is actually one of the most hemodynamically stressful events that your body's ever going to go through. A hemarthrosis as well, that's a common presentation of hemophilia. That's when you get blood into the joint cavity, it starts swelling up, and you'll take some fluid out of that joint and you'll see that it's tinged red or pink. So that would really increase your suspicion for a factor problem. SDL here doesn't talk about too much, goes into von Willebrand factor, and then talks about hemophilia A and B. So von Willebrand factor, we said, is produced by endothelial cells and by platelets, and it's kind of an adapter that attaches platelets to damaged endothelium. Von Willebrand factor stabilizes factor VIII, which is part of what makes the intrinsic pathway go forward once it's about to reach factor X. The most important function of von Willebrand factor is to promote the adhesion of platelets to the subendothelial matrix. So what I get out of this couple sentences is that a von Willebrand factor deficiency is going to screw up your platelet metrics and your clotting factor metrics. You're going to have a prolonged bleeding time because you need von Willebrand factor to put those platelets on the injured wall, but you're also going to have an elevated partial thromboplastin time, measuring activity of the intrinsic pathway. Because again, factor VIII there, where's factor VIII come into play? So we scroll back up and we look at our clotting cascade and we see, oh, look at that. Factor VIII is required at the very last step of the intrinsic pathway to turn factor X into activated factor X. So if you have von Willebrand disease, which is very common, by the way. You're going to have not just an elevated bleeding time, but an elevated prothrombin, partial thromboplastin time. But those tests are pretty non-specific because the best way to measure von Willebrand disease is with the ristocetin cofactor assay. Means that if you're missing von Willebrand factor, ristocetin normally is going to cause platelet agglutination, platelet aggregation. But if you're missing von Willebrand factor, the platelets will not clump at all. So you put patients' platelets in a test tube, add ristocetin. If they have von Willebrand factor, it'll clot. If they don't, it won't clot. Real specific test, as you can tell. Not a lot of what would that be? False positives on that. So von Willebrand disease is a deficiency of von Willebrand factor in which you just bleed a lot. And this is common in women. It's an autosomal dominant disease, one of the most common autosomal diseases in the world. 1 in 250 people have von Willebrand disease. And you want to treat it with desmopressin, which upregulates the synthesis of factor VIII and von Willebrand factor from the liver. I'm sorry, factor VIII from the liver, von Willebrand factor from endothelium and platelets. So desmopressin is a really good treatment. Oral contraceptives also do increase the synthesis of both of those things, factor VIII particularly though. Von Willebrand disease, easy bleeding, autosomal dominant, PTT is up, bleeding time is up, do a ristocetin test. Now let's talk about hemophilia. These are X-linked recessive diseases. What does that mean? That means only males present with the disease. Females are just carriers. Now, it's a mutation on chromosome X, X-linked. And A and B and C, these different hemophilias, are just called different things because they affect different clotting factors. Hemophilia A is a factor VIII deficiency. So that'll be an elevated PTT, intrinsic pathway involvement. Characteristic symptoms include those deep bleeds, like the hemarthrosis, or maybe the post-surgical bleed, because again, you can get platelet plugs. You don't have a platelet problem at all if you have hemophilia. So you cut somebody open and you stitch them up and it'll have a platelet plug on top of it. But if they move around too much, that plug's going straight off and then that's it. So the bleeding, the degree of bleeding in hemophilia can very often be fatal, depending on the surface area of the wound. How do you treat it? You need to give them factor, and you need to give them the specific factor that they're missing. So figuring out, oh, this patient doesn't have 8, or they don't have 9, or they don't have 11. That's important. Versus a patient with low platelets, you can just give them a platelet pack, and they'll be pretty good. So hemophilia B, in this SDL, there's not a ton here. They tell you the exact same things that you see with hemophilia A. You're going to bleed after surgeries. You're going to bleed after tooth extractions. That's the easiest way to ask a patient. I mean, screen a patient for hemophilia. You ever had a wisdom tooth out? Oh, yeah, sure. Did you bleed a lot? No. Okay, you don't have hemophilia. So you can put that to use practically. Again, hemarthroses, I mean, they're telling you patients got hemophilia, basically, when we're taking these standardized tests. Elevated PTT, normal PT, extrinsic pathway, again, that's only factor 7. You're cool there. Bleeding time in hemophilia, normal. Okay. So now we get to DIC, which is, we've talked about platelet problems. We've talked about factor problems. DIC is a little bit of both. In fact, it's like you have 2 diseases at one time. The first disease, well, first let's break apart the name. What's it mean? DIC. Disseminated all over the body. Intravascular, inside your blood vessels. Coagulation. So all over your body, inside your blood vessels, you're clotting. That's DIC. It's really two diseases. First and foremost, you have clots everywhere. So there's the coagulation part of it. But also, because you have clots everywhere, you're using up all your platelets and you're using up all of your factors on these clots. So you end up with the thrombocytopenia and a factor deficiency. That's why this is life-threatening. It gets to the point where it's like, well, okay, one more bleed and you're done for, one more bad bleed, because you don't have the factor and you don't have the platelets to stop it up with hemostasis. Now, going back to this one table here, notice that with DIC has involvement of all these pathways that we've talked about so far, which is why it's at the end of this SDL. You've got a low platelet count and a prolonged bleeding time because you are consuming platelets. There's so much systemic endothelial damage that your platelets are just grabbing on everywhere. Now, there's so much clotting going on also that both your intrinsic and your extrinsic factors are depleted. So PT, PTT, both those are prolonged, elevated. That sets DIC apart from every other pathology that we've talked about in this SDL. If you've got a platelet problem, let's say you got idiopathic thrombocytopenic purpura, right? It's thrombocytopenic. You have low platelets. You don't have platelets. What's your bleeding time? That's a measure of platelet function. It's elevated. Okay, but then you get to the factors and it's like, what's your PT? Normal. What's your PTT? Normal. No factors involved at all in a thrombocytopenic purpura. No, nothing to do with factors. Another plateletopathy, TTP, HUS, due to a bacterial toxin or due to that ADAM-TS protein being deficient. What's your platelet count? Low. What's your bleeding time? High, because that's a measure of platelet function. What's your PT and PTT? Totally normal, because those measure factors. Then you have a factor problem, okay? Let's say you have hemophilia. Well, that's a factor 8 deficiency. So factor 8 is that intrinsic or extrinsic pathway. That's intrinsic pathway. So if you don't have it, intrinsic clotting is prolonged. Has nothing to do with factor 7. Extrinsic pathway is normal. Has nothing to do with platelets. Bleeding time is normal. Platelet count is normal. That's hemophilia. We talk about von Willebrand's disease, in which you got a factor 8 deficiency, but also a von Willebrand factor deficiency. So that slight little factor 8 deficiency means that you've got an intrinsic or extrinsic pathway problem. Intrinsic. So PTT can be prolonged, but nothing to do with extrinsic, so that's normal. And then because you have a von Willebrand factor problem, platelets are not going to be able to stick to injured endothelium, so bleeding time is prolonged, but there's a normal platelet count. It's not a platelet problem, it's an adhesion problem. So that's von Willebrand disease. And then taking us back to DIC again, that's the one where everything is messed up. Every single blood metric is out of whack with DIC. And it's so bad to the point where D dimers are elevated. And you might see that phrased as something like fibrin degradation byproducts. You know, they won't always say D dimers in a test question. They will in real life, but elevated D dimers too. That's how bad it gets. Causes of DIC, good acronym, mnemonic, one of those two. It's stop making new thrombi. That's in first aid. It's like sepsis, SLE, trauma, obstetrics, and pregnancy, malignancies, nephrotic syndrome. And one more thing, can't remember it, but good mnemonic there. Pathogenesis, what's going on? Again, you got two different diseases. First, you're clotting everywhere, so you've got clots. And then second, you can't clot at all because you're depleted of factors and platelets. And DIC is going to be triggered by widespread endothelial damage. That's why we see it in ICU patients, because they've got cytokines in their blood that just get endothelial cells so angry, they go off the wall. So again, think about it, like snake bite, sepsis, obstetrics, you just lost a lot of blood in some cases. Trauma, there we go. Cancer. So things that put a mass amount of inflammatory substances into the bloodstream cause mass platelet activation. And widespread platelet activation leads to thrombocytopenia. I should have just been reading from this chart all along, I'll tell you. You get the platelets, you get the clots, and so then you get the factor depletion. So not only do the little clots lead to tissue ischemia, hemolytic anemia, and this is widespread tissue ischemia too. I mean, this is like big surface area. Big surface area here in DIC. That can go to the brain, they can go to the kidneys. These clots can go anywhere. They can start up in any organ. You could get a clot in your adrenals. That would be Waterhouse-Friedrichsen. You can get a clot in your lungs. So not only do you have clots everywhere, you also eventually get really extreme bleeding. And that's typically where the mortality comes in the loss of life in DIC, is due to this hemorrhaging that's refractory to volume treatment. Another important point here in the middle, fibrin split products as clot remodeling takes place. What does that mean? That means D-dimers. So D-dimers are the laboratory hallmark of DIC. How do patients present? Well, don't forget that the causes of DIC, because if they want to tell you the patient's got DIC, they have to give you enough background to tell you they're pretty sick. You got to be in a bad shape to start with to get DIC. It's very rare you just spontaneously get DIC. No, there has to be something like shock in the case of trauma or obstetrics. There has to be something like multi-organ failure in the setting of cancer. There's got to be something really bad before you get DIC. So that's always going to be part of the presentation too. Now, your job is to recognize when things go from just really bad to really bad plus DIC. And you'll visually be able to see this when the patient starts developing symptoms of thrombocytopenia. So that's going to start off as your classic mucous membrane petechia, maybe petechia on the hands, elbows, flexor components, and it'll progress, and those petechia will get worse and turn into wider and wider bruises as the patient gets more and more depleted of platelets and clotting factors. And it can lead to a presentation quite like this. I mean, dude's leg, both legs are just purple here. Why? Well, because his capillaries are bleeding out and there's nothing left in the body to stop those bleeds from occurring. So again, you combine this with a lot of clots floating around the bloodstream that could potentially occlude the brain or the heart or the kidneys or the adrenals or the lungs. That's why this is such a bad thing. And at the end of it, when patients can't coagulate, then they're really going to be bleeding like even just the most minor abrasion of their gums or their eyes right there, the corners of their eyes, is going to cause them to get a little bit of a bleed going. So you start noticing that, that's when you can say, okay, we're going into DIC here, roll up your sleeves. One more time, D-dimers are going to be very elevated in DIC, and that's the only condition in this whole SDL that you're going to see high D-dimers in. I think this at the top of page 12 is a good graphic for understanding the sequence of events. Guys, there is absolutely a timeline for hemostasis, and that's what I like about it, is it's replicable. You can just rep it enough and get it down cold, right? So you've got endothelial injury, you've got von Willebrand factor, platelets bind with GP1b, ADP degranulation, platelets bind to other platelets with GP2b3a, cross-linking with factors. There you go. Like, that's hemostasis. So just keep repping it, and you're going to get it down cold too, if you don't already have it. And as for wrapping up this material, I would say one more time, you see this on a test, they're going to give you something about some kind of blood metrics, and that's going to steer you to the diagnosis. So understanding that bleeding time is a measure of platelet function only, and that PT and PTT measure factor function, that's what you need to pick apart these questions and really have no trouble with them. Thanks very much. This was a big one.